It's my pleasure to offer a discussion today on cervical artery issues and chiropractic care in an update format on a series of 4 areas of interest and concern relative to recent publications and information that has been made available in the literature over the course of the past few months to a couple years. The areas that we're going to be looking at today fall into 4 categories. The first is epidemiology. The second is blood flow alterations based on cervical spine position and movement. The third is hypertension and its role, if any, in the question of cervical artery dissection. And the fourth is increasing the safety of cervical spine adjusting in relationship to cervical artery issues. Now, in each of these sections, as I go through them, I'll identify a series of articles that the conversation will be based upon, and the full citations are on the slides, as you can see. I'm not going to bother reading each of those. You can revisit those at any time. You can also track them down online. You can generally find almost all of these on PubMed at PubMed. And if you were to enter any of the titles into the search engine, you'll find the full articles, or at least the abstracts and places to go to access the full articles. So relative to epidemiology, there's a series of articles that are of utmost importance to us as chiropractors in this discussion of cervical spine adjusting and its relationship, if any, to vertebral artery and internal carotid artery issue. The most important paper in the history of the profession and the history of this discussion comes from Cassidy. It was published in Spine in 2008. And one of the key conclusions that Cassidy and his colleagues offered to us was that the increased risks of vertebral artery stroke associated with chiropractic care and primary care visits is likely due to patients with headache and neck pain from VBA dissection seeking care before their stroke. They go on to report that they found no evidence of excess risk of VBA stroke associated with chiropractic care compared to primary care. Let's unpack that just a little bit. What Cassidy has put on the table and begun a shift in thinking about this process has to do with the sequence of events. Prior to this point in 2008, the thinking was that the patient had neck pain. The neck pain caused them to seek care. If they sought care from a chiropractor, they likely received an adjustment. If they received an adjustment and subsequently developed symptoms of a dissection and or a stroke, the conclusion was the chiropractor caused that problem. What Cassidy has put on the table and developed the data for and reinforced very strongly is the concept that the patient dissects first. The dissection produces neck pain and headache. The neck pain and headache causes the individual to seek care from a chiropractor or from a primary care provider, and they go on to experience dissection and stroke at an equal rate regardless of the provider that they go to. So the perspective now is that the patient dissects first. The dissection sends them to a healthcare provider, and then a given percentage of those patients will go on to experience a stroke associated with that dissection, and it is not related to the care they receive from a chiropractor or a primary care provider. And again, Cassidy conclusion in 2008, they found no evidence of excess risk of VBA stroke associated with chiropractic care compared to primary care. The concept there is that primary care experience of the rate of stroke in primary care was viewed as the baseline, and that anything in excess of that would be a matter of concern. But if the experience under chiropractic care didn't exceed that baseline, then there was no excess risk beyond the baseline. And that all rests upon the assumption that primary care physicians are not providing cervical spine adjustments, which I think is a reasonable and appropriate assumption for us to make. In 2014, there was another important paper that was published, and this one came from the American Heart Association and the American Stroke Association and was published in the journal Stroke. And the primary author of this a multinational and multi-author paper was a gentleman by the name of Biller. And Biller, in their conclusions, they identified that mechanical forces play a role in a considerable number of cervical dissections, and population-controlled studies have found an association of unclear etiology between chiropractic manipulative therapy or cervical manipulative therapy and vertebral artery dissection stroke in young patients. Again, the point that they're talking about here is association, not causation. And this is perfectly consistent with the findings that Cassidy put forward in 2008. it follows that same line of reasoning that was laid out by Cassidy and his colleagues. Bill goes on to note the incidence of cervical dissection in CMT patients is probably low and causality is difficult to prove. And their recommendation is that they strongly consider the possibility of cervical dissection and inform patients of the statistical association between cervical dissection and CMT prior to performing manipulation. Again, consistent with common practice in the profession that we provide informed consent to patients relative to cervical spine adjusting or full spine adjusting for that matter prior to care. And they have added nothing to this discussion in relationship to the question of association or causation, and in fact confirm that causality has not been established and would be very difficult to prove. In 2015, the epidemiology discussion was extended through an article by Kozloff and Elton that was published in Chiropractic and Manual Therapies. And Kozloff and Elton work with United Healthcare and the analytic arm of United Healthcare, Optum Health, and they have a massive database that represents care data as well as commercial insurance data with a volume of patients exceeding 5% of the population of the United States. Where Cassidy and his colleagues followed patients in the province of Ontario over almost a decade, Kozloff and Elton followed patients, again, in excess of 5% of the population of the country over a 3-year period. Kozloff and Elton attempted to replicate the findings of Cassidy using American data as opposed to the Canadian data that was available in the province of Ontario. Where Cassidy found an association between cervical spine adjusting and the risk of VBA stroke, Kozloff and Elton found no significant association between exposure to chiropractic care and the risk of VBA stroke. They go on to note that manipulation is an unlikely cause of VBA stroke. The positive association that is found between primary care visits and VBA stroke is most likely due to patients' decision to seek care for the symptoms of headache and neck pain of arterial dissection. If we compare Cassidy and Kozloff, Cassidy indicated that there was an association between chiropractic care and VBA stroke that was similar to the association between medical care and VBA stroke. Kozloff has found no association between chiropractic care and VBA stroke, but the positive association persists in their findings between primary care visits and VBA stroke. And again, making the assumption that primary care providers are not providing cervical spine adjustments or cervical spine manipulation. So this begins to reinforce the Cassidy findings very strongly with a different data set, but even more significant findings than Cassidy and company produced. In 2016, there was a meta-analysis and a systematic review that was conducted by Church and Associates that was published in the journal Cureus. That's C-U-R-E-U-S. This is interesting in particular because Church and the other authors involved in this paper are all neurosurgeons, and they work out of Hershey Medical Center in Pennsylvania and Johns Hopkins University out of Maryland. They began the process of looking at all of the literature regarding this subject, and they concluded, quote, "Our analysis shows a small association between chiropractic neck manipulation and cervical artery dissection." Again, this is association, not causation. This relationship may be explained by the high risk of bias and confounding in the available studies, and in particular by the known association of neck pain with cervical artery dissection and with chiropractic manipulation. Their point being that neck pain and headache are commonly associated with cervical artery dissection, and they're commonly associated with chiropractic care apart from dissection. And their conclusion is that there is no convincing evidence to support a causal link between chiropractic manipulation and cervical artery dissection. And again, this was from the journal Cureus by a series of neurosurgeons. The second area that we want to approach today has to do with blood flow alterations based on cervical spine position and movement. One of the theories that has been floated over the years is that the normal positions that an individual can place their cervical spine in can alter the blood flow pattern in the neck, and as a result to the posterior brain, in particular, the perfusion to the posterior brain. And further, that there could be the potential that the positions that we place patients in prior to an adjustment or during an adjustment could also alter the blood flow to the cervical spine and create a hemodynamic change that could potentially injure or set the stage for injury in the vertebral artery or in the internal carotid artery. So the next series of articles will look at this question of blood flow, and we'll go through this. Some of these go back 20 years, and some of them go back. So we're going to be looking at a spectrum of thinking to see how it has changed over that 20-year period, to see what we know at this moment about this subject area, and if there's anything that we need to draw from this to provide better and safer care for our patients. The articles are available for you to review on PubMed or any other search, and again, you simply enter the titles below and you can bring up any of these articles that you'd like to. There's a series of 5 that we'll look at to a greater or lesser extent along the way, and again, as I said, they cover about a 20-year window of time. So let's go back to 1998, and this is by Licht et al., and it appeared in JMPT, and in their conclusions they state this is the first study comparing flow velocity in the vertebral artery before and after spinal manipulative therapy. So in 1998, the chiropractic profession began the process of looking at the question of, does an adjustment or the process of an adjustment change the flow of blood in the vertebral artery and or the internal carotid artery in the simple performance of that procedure. Licht and Associates reported that they found no significant changes in otherwise healthy subject with a biomechanical dysfunction of the cervical spine. So they have otherwise healthy folks that need an adjustment, the biomechanical dysfunction being a subluxation, and they need an adjustment. They did note that major changes in peak flow velocity might, in theory, explain the pathophysiology of cerebrovascular accidents after spinal manipulative therapy. So again, we're talking 20 years ago, and they're putting forward the idea that if we have peak flow velocity changes, could that sudden change in velocity cause damage to the intima of the artery and set the stage for the development of a dissection and or a stroke downstream? And they go on in their conclusions to note, in uncomplicated spinal manipulative therapy, this potential risk factor was not present. So their theory, or the theory that had been put forward prior to 1998, that in the process of an adjustment, we altered blood flow or blood volume or velocity in a fashion that caused a hemodynamic change to injure the artery, was relatively set aside by this study in the concept that they could not find evidence of that potential risk factor being present in 1998. The second article we're going to look at in this grouping was authored by Jarius Quesnelle at CMCC and Associates, and it was published in 2014. And Quesnelle and his colleagues looked at the side-to-side differences between ipsilateral and contralateral velocities and flows throughout a series of conditions, those conditions being neutral positioning of the neck, 45-degree rotation, maximal rotation, and during the process of a cervical spine. They note in their results that there were no other interactions or trends toward a difference for any of the other blood flow or velocity variables. So in those variables of the neutral position, 45-degree rotation, maximum rotation, and during the adjustment, they found no alterations in blood flow or velocity that changed in that process. In their conclusions, they state, there were no significant changes in blood flow or velocity in the vertebral arteries of healthy young male adults after various head positions and cervical spine manipulation. Again, this reinforces the work that Licht did 15 years earlier, and using MRI studies, they have established the idea that we're not seeing significant changes as a result of the positioning of the neck, again, either in flow or velocity. Again, the hemodynamic situations that are likely to alter the structure of the artery or damage the artery, and neither of these are changing. The third paper to look at was by Thomas, and it appeared, I believe, in 2015. And among their conclusions, they state, it appears that in healthy adults, the cerebral vasculature can compensate for decreased blood flow in one or more arteries by increasing flow in other arteries to maintain cerebral perfusion. Sustained end-range rotation may therefore reflect the compensatory capacity of the system as a whole rather than an isolated vertebrobasilar function. Again, let's unpack this one. What they're talking about is looking at the system of blood flow as opposed to the flow in one single artery, the right vertebral artery or the left vertebral artery, for example. And what their point is that in normal circumstances, there is compensation within this blood flow structure, the way the system is designed, the way it's supposed to work. It's not an abnormal change, it's a constructive, adaptive change to normal motions and activity. And the net result is that the body has the ability to compensate for changes in one vessel by the activity in another vessel and in the whole to maintain complete perfusion throughout the posterior brain with the, again, circulation from the vertebral as well as the internal carotid. We move on to an article, I believe it was 2019, by Mosier, and in their conclusions they state, "Our results are in accordance with previous work, which has shown a decrease in blood flow and velocity in the contralateral vertebral artery with head rotation." Now this is a little bit different than what Quesnelle said. Quesnelle said they found no changes. Licht said they found a change, and then Thomas said that the change was fully compensated for within the system. So what Mosier is saying is that they have established the idea that when we turn the head to one side, there's change in the opposite vertebral artery. And again, that's not a pathological change, that's not a concerning change, that's the way the system is supposed to work. They go on to note that this may explain why we also observed a decrease in blood velocity with manipulation because it involves neck rotation. Whether an individual turns their neck to look over their shoulder to back their car out of their driveway, or their neck is turned in the process of an adjustment, the net effect of rotation is the same as their point. And Mosier and Associates go on to note that our work is the first to show the cervical manipulation does not result in brain perfusion changes compared with a neutral neck position or maximum neck rotation. This is very important. The discussions we had earlier relative to blood flows was related to the hemodynamics. Is that does the pattern of flow in the artery have the potential to damage the artery? This article is now addressing the idea that let's set that issue aside and say, is enough oxygen getting to the posterior brain during the processes of an adjustment or during the processes of neck rotation so that no harm is caused to the brain regardless of whether the artery is damaged or not? And Mosier and Associates established the perspective that the rotation, even the rotation associated with maximal, as you might experience with an adjustment, do not result in changes in perfusion of the posterior brain. The changes observed were found not to be clinically meaningful and suggest that cervical manipulation may not increase the risk of cerebrovascular events through a hemodynamic mechanism. So now we're looking at a second mechanism. The first mechanism was the alteration in the blood flow pattern itself. Now we're looking at alterations in the content of the oxygen that are reaching the brain, and again, no negative impact upon the perfusion of the brain is what Mosier and Associates developed. The next article to look at is from Kranenberg, and Kranenberg and Associates are out of Europe, and they completed a systematic review of the literature regarding cervical spine adjusting and the safety associated with it. And it's important for us to consider how extensive their efforts were. They began with a group of 1,453 identified studies. They culled that down to 31 studies were included in their analysis, and those 31 studies represented 2,254 individuals as participants in those studies. They go on to note that most studies mention no significant hemodynamic changes during maximal rotation. Again, consistent with everything that we've seen in the 4 articles that we've preceded this conversation with. A significant decrease in hemodynamics was identified for the vertebral artery with a hemodynamic decrease in the position of maximum rotation and combined movement of maximum extension and rotation. Again, this is the normal activity of the artery where we have the contralateral change that we discussed in the previous slide. A similar pattern of decreased hemodynamics was also identified for the internal carotid and intracranial arteries. 3 studies focused on high-velocity thrust positioning and movement. None of the studies reported hemodynamic change. It's important for us to appreciate that because what they've talked about is the range of studies that have looked at simple motions, motions associated with cervical spine adjusting, and motions specifically associated with high velocity thrust. And their conclusion, none of the studies reported hemodynamic changes. The synthesized data suggest that in the majority of the people, most positions and movements of the craniocervical region do not affect blood. Again, their statement about most is simply they can't make a blanket statement and say every. They don't know what every situation would be, but they do know what the expectation of the majority or most would be. And in their conclusion, they state, the findings of this systematic review suggest that craniocervical positioning may not alter blood flow as much as previously expected. This is an important acknowledgement because Kranenberg has previously written articles that suggested there was more concern in this area than this article reflects. So as the literature has evolved and as the research has evolved, so has the position of several key individuals commenting on it, and Kranenberg being one of those people who now does not see the concern in craniocervical movement reducing or altering blood flow changes to the brain that he once did. So that takes us to the third area that we want to look at, and this has to do with hypertension and its role, if any, in the question of cervical artery dissection. And before we get into the specifics of that, it's important for us to acknowledge that hypertension in relationship to ischemic stroke is a huge factor. So when I say hypertension and its role, if any, it's specific to the question of cervical artery dissection, not ischemic stroke in general. There's no doubt about the fact that hypertension is strongly correlated with ischemic stroke throughout the brain. But we have to keep in mind that we're looking at one particular type of stroke that represents less than 0.5% of all strokes that exist. And that is strokes that arise from a dissection in the cervical artery system. And again, whether that be the vertebral artery or the internal carotid artery. So the question then becomes, in that unique type of stroke origination, is hypertension a factor? And if so, how consequential is it in this perspective? So that's the question we're going to look at over the course of the next 5 or 6 studies that we look at. And again, as with the other content areas that we've examined so far, we have a series of articles for you to consider. And again, you're welcome to look at those at your leisure. So let's go back to 2006 and an article by Pizzini. And from the abstract, we can take the following quote. A trend towards significant association was seen when the prevalence of hypertension was compared among patients with spontaneous cervical artery dissection and controls. Okay, let's again unpack that discussion. So there is a trend toward a significant association. It does not say there is a significant association. It says there's a trend toward. And they're comparing the prevalence of hypertension among individuals who have spontaneous cervical artery dissection versus their control group. The percentages were 26.8 versus 17%. They go on to note that hypertension was also significantly associated with a subgroup of patients with spontaneous cervical artery dissection and cerebral infarction. So what's the difference here? In the first discussion, we're looking at the prevalence of hypertension in dissection with or without stroke. And in the second sentence, they're looking at the presence of hypertension in the persons with dissection with cerebral infarction or stroke. And they note that there was significantly associated with a subgroup of patients, hypertension was significantly associated with a subgroup of patients who had spontaneous dissection and cerebral infarction. And they go on to also note, and finally note, that this was particularly significant when involving the vertebral arteries. So in 2006, we had the discussion that came forward from Pizzini that says there may be something there relative to spontaneous cervical dissection and a control group. There probably is something there in relationship to persons who have a spontaneous dissection and a stroke, and it's even a little bit stronger in relationship to the vertebral artery if that's the origin of the dissection. We move forward from 2006 to 2011, in an article published in Circulation by Debet. And this is a very important article. This comes from a multinational, multi-center collaboration that was completed in Europe called called the Cervical Artery Dissection Ischemic Stroke Project, and CADISP, and if you Google that, you can find all of the work that has been completed with this project, and it's quite extensive. But in 2011, published a paper, Susan Debet from France developed a paper regarding hypertension and cervical artery dissection ischemic stroke. And in the conclusion, these results from the largest series to date suggest, and if you look at your slides, the suggestion is highlighted, that's my highlighting, not hers, suggests that hypertension, although less prevalent in patients with non-cervical artery dissection ischemic stroke, could be a risk factor for cervical artery dissection. Again, the emphasis on could is my emphasis, not hers. So what is she telling us at this point? Is that the data from this large study that involved several nations in Europe is that hypertension was less prevalent with non-cervical artery dissection ischemic stroke. And it could be a risk factor for cervical artery dissection related problems. She goes on to note that hypercholesterolemia, obesity, and overweightness are inversely associated with cervical artery dissection. This is an important point because we have had criticisms in the past, or suggestions of criticism in the past, that persons with higher cholesterol levels were at greater risk for cervical artery dissection. This is one of those areas where the traditional risk factors associated with stroke don't apply. And in fact, they're protective. This is a complete reversal in thought, that the things we don't want, hypercholesterolemia, obesity, and overweightness, these are protective in this environment relative to cervical artery dissection, according to Debet in 2011. So we go on to another article by Debet in 2014. And in this discussion, she talks about recent findings. And again, the comment she makes is that in large multi-center series of cervical artery dissection patients, compared to age-matched healthy controls and patients with an ischemic stroke of another cause, hypertension and migraine, especially without aura, were confirmed as risk factors for cervical artery dissection. And again, the emphasis were confirmed as risk factors is my emphasis, not hers. In addition to cervical trauma and recent infection, so recent cervical trauma and recent infection were risk factors according to Debet. And again, she emphasized again the idea that hypercholesterolemia, being overweight, and obesity in general are inversely associated. This is a significant change. In 2011, she says her language was suggest and could. In 2014, she's written that that hypertension was confirmed as a risk factor. The problem with this is that the same data was used to support her statements in 2011 as was used in 2014. In the 2014 article, she referenced the exact same article that she referenced in 2011 as the evidence and the endnote for her comment. So if the data supported suggest and could in 2011, she put forward no evidence or no data to support the change from suggest and could to a confirmed risk factor simply 3 years later. So whether or not Dr. Debet believes this, which I wouldn't quibble with her if that's her belief, that's her belief. What I'm suggesting is that according to the literature published in 2011 and in 2014, there is no new or additional information that she put on the table to support the transition from could and suggest to confirmed risk of hypertension, which is important, as you'll see in just a moment. The next paper for us to look at comes from Norway, and authors by the name of Chiabi and Russell. And these folks have put forward a decision-making rubric for us to consider in relationship to evaluating the patient before cervical spine adjusting is administered. And if you'll notice on the slide that you have in front of you at this point, on the left side of the slide, beneath the box, you'll see ICA. And on the right side of the slide, underneath the box, you'll see VA. The left side involves the discussion of the internal carotid artery, and the right side involves the discussion of the vertebral artery. Now, let's pay attention to the internal carotid. From what Chiabi and Russell have said here is that in the event that you have a patient with a cranial nerve palsy that would involve cranial nerve 7, would involve cranial nerve 9, cranial nerve 10, 11, or 12, that you should consider, in the presence of hypertension, neck swelling, or midline pain, a referral for emergency services. Now, if we look at the recommendation relative to hypertension, you can see that they're suggesting if the blood pressure is above 140/90 and you have the presence of cranial nerve palsy, that an emergency referral is in order. Now, the concern I have regarding this recommendation is that reference relative to hypertension is based upon the 2011 DBET information and the 2014 DBET information. So Chiabi and Russell have taken the finding or the conclusion that DBET made in 2014 that hypertension was a confirmed risk, and they've brought that forward into their rubric. The question we have, based upon the previous series of slides, is hypertension the risk factor that they think it is at this point? Or has there in fact been a conflation of the significance of that by the previous studies? And then they go on to suggest that neck swelling and midline tenderness are suggestive of a fracture, are reasons for an emergency referral. I have to say I miss the logic of this. First of all, neck swelling is not a symptom of cervical artery dissection. Midline tenderness is not a symptom of cervical artery dissection. Now, if a patient has midline tenderness suggestive of a fracture, obviously a referral is in order. If the patient has neck swelling and we can't identify the reason for the swelling, there may be reason for that referral all by itself. But to suggest that the presence of cranial nerve palsies together with hypertension or cranial nerve palsies together with neck swelling is a reason for emergency medical referral before adjusting, frankly, I don't think holds up. And I'm sure the authors are very sincere in the approach that they've taken in wanting to find a method to help us screen, but I just simply don't think it does the job and doesn't get there. If we look at the vertebral artery side of the question, we see that their recommendation is that if a patient presents with cervical radiculopathy at the C5, C6 level, and hypertension, neck swelling, or midline tenderness, then an emergency referral is in order. Again, the same hypertension consideration that exists in the internal carotid artery exists in the vertebral artery, and the basis upon which that has been put forward is called into question as much on this side of the slide as it was on the other. The same two factors involving neck swelling and midline tenderness also apply. So there's a great many bits of information from this article that are wonderful and that I'll refer to in just a few minutes in another context. But relative to this rubric and relative to the perspective that hypertension is this pivotal finding, I don't think the literature supports it as they suggest that it does. Now, again, this slide talks about the very detail that I've just finished talking about, and the conclusions, their 2019 recommendation relative to hypertension is based upon DBET's 2014 citation. And again, I don't think the evidence is there to the extent that they think it is. Now, under the discussion in the Chiabi article, it's important to look at this very carefully, and I'd ask you to bear with me if this is a little bit dense on this slide. But they note, as there are known important risk factors for cervical artery dissection that have been shown to increase the incidence rate, clinicians, and especially manual therapists, should specifically be aware of the importance of history taking. We agree completely. That is, environmental risk factors such as recent acute respiratory infection, hyperhomocystinemia, low body mass index, low cholesterol, smoking, and pulsatile tinnitus have been reflected in the literature as possibly being associated with the occurrence of cervical artery dissection. If any of those things show up in the history of the patient, we'd want to slow down. Doesn't mean we have a contraindication to adjusting. It means that we want to evaluate that patient in light of those findings. They further go on to note that when inherited risk factors, the hereditary elements associated with conditions like Ehlers-Danlos syndrome, particularly type 4, Marfan syndrome, osteogenesis imperfecta, or Louis-Dietz syndrome, all being collagen disorders, all being disruptive of connective tissue, all experience increased rates of dissection of all kinds in these patients. So if you have a patient with Ehlers-Danlos or a patient with Marfan's or osteogenesis imperfecta, please be aware that they will automatically, just because of the nature of their condition, have a greater incidence of dissection no matter what happens in their life. So obviously we want to be careful with those patients as well. But if you look at this slide, the one discussion item that isn't there in any shape, form, or fashion is a discussion of hypertension. So where in one portion of this article they put forward hypertension as being a pivotal decision-making point, in this portion it's not even acknowledged. So again, I question the significance of hypertension in relationship to this conversation. I'm not alone in that questioning. In 2019, there was a letter to the editor that was accepted from two neurosurgeons, Hal Pikus and Dr. Harbaugh from Pennsylvania. Pikus is from New Hampshire, I believe, and Dr. Harbaugh is from Pennsylvania. And they comment that hypertension is so prevalent in the general population that its inclusion in a decision tree is of no practical value. And they go on to note that in some series, particularly Cassidy 2008, the prevalence of hypertension was similar in the cervical artery dissection and control groups. So there was no difference in the Cassidy study between the populations that were included in persons who had dissections and the population that was used as a control. So again, the value of hypertension in that context was drawn into question by Pikus and Harbaugh. Were responded to by Chiabi and Russell with a series of 3 or 4 additional articles, but none of which was on point to the emphasis that Pikus and Harbaugh were making regarding their original article. So it really didn't advance the conversation very much. And then finally, I'd like to come back to an article that was written by Kranenberg in 2015. Remember, Pizzini was 2006, DeBet was 2011, DeBet again in 2014, and then we had Chiabi and Russell in 2019. In 2015, we had an article by Kranenberg entitled Risk Factors and Clinical Presentation of Cervical Artery Dissection, Preliminary Results of a Prospective Case Control Study. And in this report, Kranenberg notes general cardiovascular risk factors, with the exception of migraine, were not important risk factors for dissection in this cohort. So again, Kranenberg is supporting the idea that the general risk factors of stroke are not the general risk factors associated with cervical artery dissection-related stroke. And again, he goes on to talk a little bit more in an additional article that was provided regarding adverse events that you're welcome to read at your leisure as well. So that takes us into the fourth area that we wanted to look at today, and this has to do with information regarding the safety of cervical spine adjusting regarding cervical artery issues. And what's exciting about this is that the original work that was put forward by Cassidy in 2008, suggesting the a priori nature of the dissection before care was sought, is now being taken into consideration by persons in physical therapy, by persons in medicine, by persons in other disciplines. And the reality that Cassidy put on the table, that Kozloff reinforced, that Church emphasized, is now being more widely accepted. And in these series of articles that we have before us, I'm going to go back to the Chiabi article that I spent a few minutes criticizing and now brag on. So a little schizophrenic moment for me here. But in 2019, Chiabi and Russell note cervical mobilization and or manipulation have been suspected to be able to trigger cervical artery dissection. However, These assumptions are based on case studies which are unable to establish direct causality. Very important point that Chiabi is putting forward is that case studies and even case series do not have the epidemiological power to establish causation. They simply just don't have the controls. They don't have the juice to be able to draw that conclusion. So anytime a conclusion regarding causation is drawn on a case study, it's inappropriate. And in particular, in relationship to our discussion regarding cervical artery dissection, again, to draw that conclusion based on a case is an inappropriate conclusion. And Chiabi goes on to note that the World Health Organization has identified care provided by chiropractors as safe and effective with few mild transient adverse effects. They also note that a few case studies have reported serious adverse events following cervical spine manipulative therapy, but whether there is a causal relationship between cervical spinal manipulative therapy and cervical artery dissection has not been determined. Several extensive cohort studies, Cassidy and Kozlov, for example, and meta-analyses, Church, have found no excess risk of cervical artery dissection resulting in secondary ischemic stroke for chiropractic spinal manipulative therapy compared to primary care follow-up. So it's important to see that the movement of the Cassidy perspective out into the literature on a broader and broader basis is definitely taking effect. Chiabi goes on to also bring into focus the work that was done by Walter Herzog at the University of Alberta at Calgary, as well as others such as Dr. Simons and Dr. Wust, who have evaluated the strains placed upon the vertebral artery in the process of cervical spine adjusting. And Chiabi reports that the invasive studies done by Herzog and company, etc., have further disproven any misconception as to whether vertebral artery strains during head movements, including cervical spine manipulation, exceed failure strains. And if you look at that literature, you'll find that the level of strain that is induced in the vertebral artery in the process of an adjustment is 1/9 of what was necessary to obtain mechanical failure of the artery. So the level of strain that's introduced into an artery is so far below an injury level and a damage level that it's a non-factor. And they also identified the fact that no changes in blood flow or velocity in the vertebral artery of healthy young male adults were found in various head positions. Again, this is supported by Licht, this is supported by Quesnelle, this is supported by Mosier, this is supported by Thomas, and supported by Cranenberg. And then go back to the article by Cranenberg in 2019. From their systematic review, these synthesized data suggest that the majority of people, most positions and movements of the cranial cervical region do not have an effect on blood flow. In their conclusions, cranial cervical positioning may not alter blood flow as much as previously expected. And as I noted earlier, Cranenberg in previous articles was more emphatic about the impact of cervical spine positioning and adjusting on the blood flow and has altered that view. Cranenberg goes on to note studies have been unable to identify specific variables which relate to the increase or mediation of risk for adverse events. It seems unlikely that a healthy artery would be traumatized by a therapeutic intervention alone. It is plausible that a cervical artery dissection is not an adverse event of the treatment itself, but exists in situ prior to treatment, the a priori concept. The positions and movements utilized in high-velocity thrust techniques do not seem to alter blood flow. Again, everything coming back to the same position and the same reinforcement viewpoint. Cranenberg goes on to say that it is unlikely that head and neck movement alone, even if forceful, could mechanically explain the etiology of adverse events that have conventionally been purported to be related to therapeutic interventions. The concept that a cervical spine adjustment induces a dissection that yields a stroke is not supported according to Cranenberg and the research that they have established. Finally, in Cranenberg, specifically they found that studies which focus specifically on high-velocity thrust reported no hemodynamic changes. Again, we discussed that relative to the blood flow consideration. And finally, The present data supports this reasoning, which suggests the adverse events related to cervical spine interventions might be the result of something other than the therapeutic positioning or movement of the head and neck. The concept of 20 years ago was patient develops neck pain, patient seeks care for the neck pain, patient sees the chiropractor, receives an adjustment, experiences a dissection-related symptom, might go on to have a stroke, therefore the chiropractor caused it. The current thinking is the patient dissects, the dissection produces neck pain and headache, the patient seeks care for the neck pain and headache, and regardless of who they seek care from or the procedures that are administered to them along the way, a given percentage will go on to dissect and stroke, again, apart from any intervention. And the a priori nature of the question, as opposed to the causation nature, is what has been established and reinforced in the literature. The last area that I'd like to talk about is one that we need to be aware of. In the process of your patient intake, you'll unlikely be questioning patients about the drugs that they're on. And one of the drugs that you want to be a little bit more inquisitive about is when they report to you that they have been recently on antibiotics. You might want to explore the nature of the antibiotic. In particular, you're looking to find out if that patient has been on fluoroquinolones. The fluoroquinolone that you'll most likely see in the marketplace is Cipro. And one of the effects, or one of the effects, of Cipro is that it has a potential to alter the integrity of collagen and other components of the extracellular matrix. As such, it has the potential to set the stage and be the origin of spontaneous cervical artery dissection. So when you come across a patient that has had a recent upper respiratory infection, for example, that's a risk factor that we want to be aware of. If that has been treated with Cipro, now we have a situation where the drug itself may have affected components of the extracellular matrix and set the stage for an even more concerning risk situation. There was a study completed in 2000, let me get the date on that, it's important, in 2019 by Zotoa and Pizzini, and you recall Pizzini was referenced in a 2006 article, where they looked at 284 cases, and they found that the use of fluoroquinolones, and in particular Cipro-type products, that the use of these antibiotics was associated with more than twofold increase of spontaneous cervical artery dissection, even after adjusting for other confounders. So we need to be aware of our patients that may be taking Cipro. Obviously, we didn't prescribe them, but others may have, and we need to be aware that they could be associated with the origins of a spontaneous cervical artery dissection. And again, one little factor that we want to take into account as we evaluate that patient before we adjust them and move on from there. So I hope that this information has been helpful to you, that it's given you a little bit sharper focus on the questions and the level of the information that's available to us relative to the subject matter, and that it helps you with your confidence level in the safety of your care in terms of cervical spine adjusting and the importance of being thorough and complete in your evaluation of patients before and throughout their period of care. Thanks a lot for your time.